All right, and welcome back, everyone, from lunch. I hope everyone got something great to eat and had a chance to just have a quick break before we got back here. I would like to first just extend our apologies for the technical difficulties we experienced with our breakout sessions. Definitely, this wasn't the experience that we wanted to provide to all of our participants. However, we are going to do our troubleshooting in the background and definitely work on those improvements for our other breakout sessions that will be coming up in later today and also on Thursday. But thank you all for sticking with us. And we're excited to have some more presentations and more engaging discussions along the way. So for our afternoon session, we will first have a session with three of our providers that will illustrate how they approach health equity in their own programs. First, we will start with Emily Brown, who is the Ending the HIV Program Manager at the Montgomery County Health Department. Following Emily will be Sharon Coker, who is the CEO of SLK Health Corps in Prince George's County, Maryland. And we will then close out with Kate Price, who is the Community Health Nurse Supervisor at the Dorchester County Health Department. So each of them will have about 12 minutes or so to present their various programs, and then we'll have some Q&A with our providers after that. After our Q&A session, we'll close out our day with one final presentation, bringing back Bobby Rogers, who is our Division Chief of Program, Deputy Chief of Program Improvement at the Center for HIV Prevention and Health Services. All right, without further ado, we're going to cue our presenters. Take it away.
Good afternoon, everybody. My name is Emily Brown, she, her pronouns. I'm the program manager for Ending the HIV Epidemic at Montgomery County Health Department, Montgomery County Health and Human Services. I am going to squeeze a lot of content into a short amount of time and just having a little trouble moving my slide, but there we go. I want to give a shout out to my entire team, many of whom are on today, in particular our administrator, Melvin Cawthon, our fearless leader through EHE and leading up to EHE funding, because we have gone through an awful lot of changes in a short amount of time, and it's with their amazing leadership that we've been able to do this. And Karen, if you're out there, I apologize for not putting your picture up. I got a little sidetracked. Thank you also to MDH for having us, and thanks for those who are attending. So we are Montgomery County Health and Human Services, HIV STI services here at Dennis Avenue Health Center in Silver Spring. We provide a lot of different services. HIV and STI services are just two of those, but we also have a dental clinic. We do all of our vaccination and a lot of different clinics and vital records out of this beautiful building. That is really a lovely place to work, and I think a great place to come into as a community member because it shows public investment in public health in a really sunny way. So I'm going to spare a lot of details about EHE because I think everyone here is probably fairly familiar that we, alongside our neighbors in Prince George's County in DC and Baltimore, are ending the HIV epidemic jurisdictions. Priority jurisdictions. And as such, we, like our neighbors, were asked to create a plan to end HIV, and that's what we'll be talking about today, and how equity works in that context. A snapshot of Montgomery County, I'm not going to get into too much detail, but I think many of y'all know a lot about our county. We are known to be a wealthy county, but we have, like a lot of places, a ton of inequity in a lot of different measurable ways. So the context of our epidemic is rooted in inequity that is for which HIV is just one part, right? So we have unequal health insurance access, a lot of folks who are newly arrived to the United States from places where they may or may not have had health insurance or health care access. We have, unlike our neighbors in DC, Baltimore, and Prince George's County, I think a lack of long-term HIV-related planning specific to our jurisdiction. Notably, in our plan to end HIV, we are addressing a lack of LGBTQ specific resources available inside our large 1.1 million person county. And we have an unusual situation, just like Prince George's, in that we are beholden both to DC planning and Maryland planning around HIV and STIs. And that's how we receive our federal funding and how we plan around it. So we're stuck in between worlds, and so many benefits and a few costs too come with that dual reality for us. In Montgomery County, approximately 4,300 people are living with HIV. And you all know the situation with not having super new data. So I'll just spare you the explanation about why we only have 2019 data here. We have some pretty serious disparities, but overall, our epidemic looks a lot like the other epidemics in the region. And notably, we do have a large proportion of people living with HIV and people newly diagnosed with HIV who are born outside of the US. We have an incredibly diverse county and an incredibly diverse epidemic, and that has challenges, but it also makes this public health system and our county as a whole a really beautiful and exciting place to do this work. So I'm sorry, I'm talking really fast. I just want to make sure I get through all of this, but I wanted to kind of take responsibility for some things about our work that, obviously this is in new diagnoses over the past several years. We have this major confounding factor in COVID. If we're trying to get to a 90% reduction in new cases, new transmission of HIV by 2030, this isn't exactly the way that we'd like to go about doing it. But in the diagnosis pillar in our plan, we have a lot of work to do in Montgomery County on diagnosing people early. It takes approximately 7.6 years to diagnose someone with HIV in Montgomery County from the time that they contract HIV, which is a really long time. And of course, a lot can happen to an immune system during that time. And about a third of folks are diagnosed concurrently with AIDS-defining illness when they're diagnosed with HIV. In Montgomery County, we have a lot of work to do also in making sure that folks are virally suppressed and retained in care. And relatively speaking, a low uptake of PrEP among those who, in the beginning of EHE, we defined as being eligible for PrEP. So just like everybody else, we have a lot of work to do, but differently than everyone else, we don't have a long-term jurisdiction-specific HIV infrastructure to rely on. And how this all starts and how it relates to equity, right, is that like everywhere else in the United States, and in some ways worse, we have a longstanding and growing racial inequity in who's getting diagnosed with HIV in Montgomery County. So any other statistic about HIV is, to me, less important than this one, right? It means that if interventions aren't working to reduce this gap and they're just working to get to a lower overall infection rate, we're not doing our job and we're not ending this epidemic. And again, sparing information that you all already know, it's race, but it's also an intersection of sexual orientation and gender identity that makes someone especially vulnerable to HIV in Montgomery County and elsewhere. So when we think about equity, we have to be intersectional. And so when we made our plan to end HIV in 2020, we did, unfortunately, mostly electronic meetings with stakeholders and decided that we really needed to center equity at the very basic level of our plan to end HIV and acknowledge that not just verbally, but in everything we do, we're working against inequity, that if we just let things go as they are, then we're not really going to make a dent in this epidemic. So in addition to being transparent, cooperative, person-centered, we need to be working constantly against a current of inequity that is inherently multidisciplinary, right? And a big part of our plan to end HIV, and you'll see obviously lots of overlap in our plan to other jurisdictions, is that everything needs to be multidisciplinary in nature. We, as the health department, and of course in partnership with the state and the city of DC health department, we have a responsibility to address structural inequities in addition to the inequities that we discussed earlier today, for example, in the way that case management is done, or individual level or interpersonal level inequity. So increasing routine screening in healthcare facilities, for example, is number one in our plan to end HIV. Number one strategy, number one pillar, right? So we need to work at the highest levels, at the policy level with our healthcare facilities to integrate HIV into the screenings that they provide. Otherwise, we're going to be fighting a long battle of doing one service at a time, which we know has its own equity implications. To address the fact that we have never had a campaign around HIV that was specific to Montgomery County and that was intersectional in nature, sex positive, LGBTQ inclusive, directly address the multicultural aspect of our epidemic and all epidemics in Montgomery County. We created the Do It For You Montgomery County campaign in collaboration with our Testing, Linkage, and Care Collaborative to really get awareness into all aspects of the county and county life. And that was our first attempt to use communication to say, you know, we're still going to be tackling these structural inequities, but actually in the meantime, we need to talk about this more openly, and we need to talk about how inequity in everything from representation to healthcare access is really at the center of this and our other concurrent epidemics that you may have been hearing a lot about recently. We also heard our community talking about how we didn't have enough LGBTQ specific infrastructure in the county, and without being able to build an LGBTQ plus centered or intersectionally LGBTQ plus centered physical brick and mortar location or service organization, we created what has become an annual coming together of LGBTQ health and wellness, LGBTQ friendly and LGBTQ centered health and wellness activities, performers, arts and culture, symposia, really any activities that you can think of that are adjacent to health and wellness, called Pride in the Plaza and Veterans Plaza in the heart of downtown Silver Spring. We have created a lot of lasting relationships from this event. We realized that events are not the be all end all of equity, of course, but even holding a place every year in a county, again, of 1.1 million people, that's fairly progressive. To have these conversations and to center health and wellness of especially Black and Latinx LGBTQ communities has been really meaningful. And we have learned a ton in that process. So save the date for Pride in the Plaza 2023, when we're growing into an even larger series of events and hopefully moving toward support for brick and mortar and or sustained LGBTQ plus, especially BIPOC led organizations in the county. And lastly, I just wanted to highlight that because we had a lot of conversations during planning for EHE about how often Black women especially are left out of conversations about HIV prevention, care, testing, messaging. We partnered with the Montgomery County Alumni Chapter of the Delta Sigma Theta sorority, which is a very robust chapter here in Montgomery County, to host an event on World AIDS Day of last year to bring awareness to the challenges specific to the intersections of gender and race around HIV in our county. We invited our county council, our school board, healthcare leaders, CEOs, and upper management of healthcare companies to just kind of listen to how serious this inequity is and listen to the experiences of women living with HIV, trying to navigate these systems that we create that are not necessarily serving anyone, but are definitely not serving Black women living with HIV in Montgomery County, right? So we are continuing this partnership this year, and I'm super excited to announce that we are expanding this program and creating a kind of a recognition ceremony for anyone working in Montgomery County doing strong work adjacent to health equity in the county. It could be equity in arts and culture, anyone working to reduce health disparities. We'll be honoring those folks who are nominated in collaboration with the Deltas again, but a larger, broader committee of selection as well in the second annual World AIDS Day Solidarity for Health Equity Breakfast. And I'm really looking forward to sharing the outcomes of that next year with you all. I actually have about 30 minutes to spare, but I just want to end this by saying, being invited here to talk about equity, I just want to say it's so clear that we have so much work to do in Montgomery County, of course. And I'm hoping to learn from Ms. Sharon, of course, because I really just want to honor the work that she's doing to work across jurisdictions to highlight equity in ways that I just don't think health departments are necessarily capable of doing. And thinking we're taking questions after. Thank you.
Hi, everyone. I am Sharon Coker, Executive Director of SLK Health Services. We are located in Atlanta, Maryland, which is part of Prince George's County. I first like to start by saying hello and thank you to Mr. Aaron Davis for inviting me to this platform. It's a privilege, it's an honor to be here, and I'm humbled for the experience. And thank you, Emily, for giving me kudos, but I couldn't have done my work without good partnerships like we have with you in Montgomery County. So, CBO approach to health equity. I like to start saying I'm going to apologize, but I'm not going to apologize. I do things non-traditional, and that's what I feel that's going to make the difference here in the county. So, health equity. We've been hearing the definition a lot today, and it's ensuring that everyone, Black, brown, yellow, blue, male, female, transgender, everything under the sun has fair and just opportunity to obtain their highest level of health. But what does that really mean if a person does not know what the word health equity means? So that means as providers, we have to really educate. A lot of times we're talking the language amongst ourselves, but how we disseminate this information to the community so that they understand, so they know, wow, I have access to this. So why is it important? That pretty little picture to my left, that beautiful little thing right there, this right here, this COVID actually snatched the Band-Aid off of everyone. It left everyone and everybody vulnerable. So if you didn't want anybody to know your truth, COVID made everyone see your truth. And so in doing this, we know that doing things the normal way cannot, because we were all functioning to function, moving as daily pace, ignoring some noise, but just keep moving forward. But COVID made everything stop, literally stop on a dime, and then reprogram. So how does organizations reprogram and move forward so that we're not going back to the same old, same old? And so what SLK did, we call it changing the narrative. There's 4 areas that I feel that's more important, that's really important for us to make a difference. That's hours of operations, outreach, staffing, and partnerships. But in hours of operation, what does that really mean? We know that everybody, primarily in the future, in the present, is always that traditional 9 to 5, 8 to 4. If you go to DMV, you got the hours. You go to bank, you've got those hours. But does everything happen in those hours? Absolutely not. And so with this experience, we've got to make sure that we are making things comfortable for the community, especially if you're saying we're there to meet people where they are. If I am on drugs and I am out all night long, or I've been traumatized where the night is traumatizing to me because of things that happened to me in the previous, I may be up all night. So likely I will not be up first thing in the morning. I may not get up until 4 o'clock in the afternoon. Therefore, where can I go if you're already shutting down for the day at 4:15? Because at 4:30, you probably already headed to the parking lot. Open on weekends. It's not being open just because you have an outreach event, but you have a full staff or enough staff to say if someone came in, needed some food, we're there. They've got 2 jobs, because we're not going to say just a disenfranchised community, because HIV affects everyone. So there could be that working mom or dad who may have 1 or 2 jobs that we don't want to say, hey, take off your part-time job to come to office to give you eligibility documents. No, we don't do that. So therefore, what does your weekend hour shift look like where it's available to the community? Because again, it's not about us. It's about the people in the community who we're trying to serve in order for us to change the narrative. And then in meeting people, it's not always in the brick and mortar, because sometimes, depending on where they live in the rural areas, they may not have that local transportation. And as we know now, Metro and things are just now starting to operate on a new normal regular basis. So are we willing to meet them at their home? Are we willing to meet them at their job on their lunch hour? Are we willing to meet them at a park that's nearby because they're not comfortable with us just yet? Or what about shopping centers? Hey, I've got to go out, run and get some food. The kids at home, but I've got 20 minutes. Can you meet me there? So what are we willing to do as an organization to meet people where they are? And then for staffing, again, this pandemic, it kind of shifted things, where some of us are working parents who have children in school. So we made adaptations, so that parents who had to homeschool, you had the flexibility. And everybody would not be available from 9 to 5. Where that person has a full-time in school because they're trying to further education, get that higher ranking job within the organization. So what's your hour shift? Is everything at 6 o'clock, or we extend to 8 o'clock at night? Maybe 9 o'clock at night, maybe 10 o'clock at night. And mental health days. It's important that everyone has a place where they can dump everything they've been receiving, because this season, people are full. And again, we're still all part of the same process. So if I'm full dealing with my stuff and I come to work and deal with their stuff, how am I getting it off of me? And so I say leaders of organizations, the smaller the better. It can be kind of challenging for bigger organizations, but you need to really check in with each employee that works with you. And if they're full, let them step back a day. Just step back, because you can't pour from an empty vessel. And if it's struggling on the bottom, at the low end, at some point, it will be bone dry to where they've given up hope. And if we employees have given up hope, how can we give hope to the next person if we're so full? And then this is the opportunity to build the volunteers, because everybody may be so isolated, they need to get out and do something. This was a season of give back, truly a season of give back. So this was an opportunity. Hey, churches, how can we help you? Open doors, young people. This was a scary season. How can we help them understand it and understand people that are going through things? Because it may be a conversation we have that maybe their home structures cannot manage because they're still full. And so this is, again, an opportunity to build your organization, kick people off in that middle height where they can come down a little bit, still help the community and still give back, and everyone's the happier. And then let's talk about leave no stones unturned. We're now starting to see traditional health fairs. And Miss Emily, I could tell you that plaza, Park on the Plaza, that was phenomenal. That was phenomenal. And so we're hoping that other counties would do something similar to it. I'm not sure they can outdo it, but it was a start, because you brought so many providers together that may have never had even a conversation. And it's important because not one organization can do everything. We all need each other at some capacity. And so we've got to learn that we have to stop working in silos, because we all have the same end goal, to end the HIV epidemic. But let's talk about the hotspots. There are new hotspots now. There's barbershops. If we're trying to reach people of color, men of color, make it easier for yourself. Where do most men go to? They always love that grooming. They love to jump to their barber. So why are we not taking advantage of those opportunities when there's already a gathering there? We're making jobs easy for ourselves. House parties, they're coming back. But we found the last 2 years, people were just trying to bring families together. But in those conversations, that's where we kind of like put our 2 cents in and talked about it. Mental health is big. It's also been that pink elephant in the room. But as we're allowing people to open up, that's when we start talking about HIV, because people are like, wait a minute, it's COVID time. Isn't HIV still a thing? Yes. In the midst of a pandemic, the HIV was still an epidemic happening, and it's still growing. And so now we talk about colleges. Students are going back on campuses. We're on these campuses, but are we there just to test, or are we there to have these hard conversations? Because you take a test, here's your papers, you're negative, have a good day. That means nothing to a person. But if you sit down and say, hey, why do I see you week after week? Why are you crying the same thing week after week? Maybe we need to change our conversation so that when they walk away from us, they're like, oh, you know what? I got Miss Emily on my shoulder. I remember she said, no, thank you. We're not saying stop. We're just saying change the way you do things. But while we're on campuses, let's take advantage of talking to these department heads. Because again, we can't do all the work by ourselves. We need a frontline soldiers. And so we need others to sow the seeds that we're supporting to them. So go to department heads, psychology departments, the health departments, the English department, school teachers, because they're being challenged now with children in elementary. Hey, I want to be called them. How are they learning? What does them mean if they've never had that conversation themselves? So this is an opportunity for small organizations, large organizations to go into these universities and meet with the department heads. Gyms are opening back up. And we all know there's a lot of things happening in gyms. If not, ask me later. liquor stores. This is where you meet a lot of the disenfranchised, a lot of the people who are struggling with life in general, those who are homeless, those who are suffering in silence, and no one wants to talk because they don't look like us, but they are us. It's just one situation away where we could have been in that same spot. So again, take advantage of these spots here. And you know, these owners, they appreciate that you're coming around because you're changing the landscape. It's not all the negativity. You're bringing hope to people. And shopping centers, people are moving about now. Again, you're taking every opportunity you can to start giving that information out there, because in the midst of the pandemic, the HIV epidemic was still happening. And so partnerships, I can't say enough, partnerships matter. Strong communication, partnerships matter. This is picture here today. We had the National HIV Testing Day this past June 27th, and we were awarded a proclamation from the city of Laurel for being recognized of the work we've done in HIV testing, because they see the value in the work we do. Get to know your county officials, get to know your local officials, because they too, they have an agenda, and public health is part of it. And here in the toolkit, if you don't have access to food banks, PrEP services, STI services, dental services, mental health services, drug treatment, HIV services, housing, and returning citizens programs, you've missed a boat. Because if we talk about health equity, we have to do the whole person. And sometimes before we can even talk about, do you want to take an HIV test? We have to ask this mere question, how are you feeling today? How are you doing right now? And if a person says, you know what, I'm done. I'm done the last, I can't get high anymore. I'm done. I'm ready for clean. I want to go to rehab. I can assure you, if you can get that person to their drug treatment program, they're going to come back and say, thank you for helping save me. Now, why were you out there that day anyway? Then you can start those conversations. So as we can't just jump out there, we have to peel back the layers. But wherever they are, you start there. And so this picture here called The Wall, this is a community in Capitol Heights where drug users, homeless people congregate on a regular basis. And what we did, we partnered with another organization, Mission of Love, in which we went out there and we brought food and fellowship. We played some tic-tac-toe, some checkers. We brought some music, had some lunch. And then we talked about clean needles. Then we talked about condom usage. Then we talked about HIV testing, the importance of it. And to the point where they said, you know what? We want to have a meeting every other week, to which they created this wall. They designed what this wall should look like. And so as you see here, we're out there on a Thursday afternoon, about 12:30, 1 o'clock, and we're setting up to have lunch with them. But also that day, we brought out students from Bowie State University, nursing students who are taking a course called community nursing. And they partnered with SOK to now I'm taking them out to community and say, hey, this is what the community looks like. Each one, teach one, touch one. So then now that you have all your community partners, I know if somebody is needing newly diagnosed, but they're at the Metro stop up in Montgomery County, I know Emily Brown at the Montgomery County Health Department is who I'm going to reach out to. I know if there's somebody up in Baltimore who just got a drug treatment, but they need some HIV syrup PrEP service, I know Aaron Days, the health department, along with other agencies we partner with, is there. So what does your network look like? Because again, no one agency has everything. If they do, they may not have the expertise level that is needed for that one particular person. And so once you get your network together, bring them all together. Because if it works good for you, there may be something that they are lacking too. And so now you're building a stronger bond with a whole bunch of people that they can appreciate, you know what, they bring value to my organization. I want to work morally with this organization right here. And so right here, I always say change the narrative one conversation at a time. And so I want to show a video, and it's comprised of our organization in action. And that's what the community wants to see. They love to see posters. They love to see where you have events, but they want to see it consistently. So like Miss Emily, she had the videos, she had the pictures of people taking tests. She had the fashion show. She had young people, a kickball tournament. You saw those pictures posted all the time. And this is where the community says, I want to be able to trust an organization with my truth, whatever it may be. But I need to know that you're still connected to the organization, because it's not just about you all, but how are you invested in people in the community partnering up with you? Well, skip the video. It's actually on our website. So if I can go to the last click here. Here's our information, our website. You'll see all the videos. We've got something called the Sharon Show animated to talk about different topics. And it's on WhyHo now. And thank you so much, Aaron.
Hi, my name is Kate Price from the Dorchester County Health Department. I will be sharing with you a QI project that was done in regard to HIV case managed clients. The goal of this project was to measure and improve client retention to care. There are various reasons that we chose retention and care as our QI project. First, one of the most important functions of HIV case management is to help improve client adherence to care and treatment, which is imperative to keep clients' viral loads undetectable. Secondly, there were multiple barriers making it increasingly difficult to track upcoming client appointments and supplemental healthcare needs with our regional HIV care provider. And lastly, the rate of retention and care for clients case managed by the Dorchester County Health Department was only 64.8%, showing that improvement was needed. Before establishing our goal for the project, we first had to define retention and care. And HRSA defines retention and care as having 2 medical encounters at least 90 days apart, one encounter being an HIV medical visit, and the second being either a medical visit or a lab draw. We use the SMART approach when developing our goal, and SMART is an acronym for specific, measurable, attainable, relevant, and time-based. Our goal was to increase the percentage of clients who meet the HRSA definition of being retained in care from 64.8% to 75%. This would be an approximate increase of 10 clients being defined as retained in care over the next 12 months. During our QI project, we used the PDSA cycle, which stands for Plan, Do, Study, Act. Our model for improvement included stating what we are trying to accomplish, how we will know if there is an improvement, and what change can be made that will result in improvement. For this project, a change was considered an improvement if it increased the number of clients who met the HRSA definition of being retained in care. During this project, we implemented various tasks, which included tracking upcoming scheduled appointments for HIV medical visits and lab draws in a custom field in CareWare. We interviewed clients before scheduled appointments to identify potential immediate barriers preventing them from attending their appointments. And we interviewed clients after their scheduled appointment to discover whether it was attended and why or why not they were able to attend. This slide shows the custom form that Clarissa Hill was able to create in CareWare so that we could track upcoming scheduled appointments for HIV medical visits. This form also allowed staff to identify barriers during a pre-appointment screening and post-appointment screening. The pre-appointment screenings took place 1 to 3 days prior to a scheduled appointment. It was during this time that staff contacted the clients to assess for possible barriers that they had that would keep them from attending their appointment, and the barriers were then documented on this custom form. Then the day of or the day after the appointment, the staff contacted clients again to ensure that their appointment was indeed attended. If it was not, the staff would utilize the form to again document the barriers that prevented them from attending their scheduled appointment. At the end of the project, 90% of the clients had been interviewed, and at least one barrier was identified for each client, and one barrier was removed for each client. 90% of the clients that were contacted did attend their appointments, and 90% of the clients felt that appointment reminder interventions were helpful in assisting them to keep their scheduled appointments. We encountered various challenges during the project. First, the project was done in 2021. So COVID provided a large challenge in regard to staffing because during that time, staff was often assigned to assist with COVID activities. Communication was another challenge because client appointment dates and times were not easily accessible to staff. Clients were also not always forthcoming in regard to the barriers that they had, preventing them from attending their appointments. And clients did not always have a working phone, so they were unable to receive appointment reminders and were not able to participate by phone in the pre and post appointment screenings. Another challenge was that barriers could be subjectively interpreted, and different staff would sometimes come to different conclusions in regard to identifying specific barriers. Some solutions that we implemented were having staff work together as a team to share the responsibility of QI evaluations. This was important because, again, staff was periodically required to participate in COVID duties. Another solution was having staff work more closely with our regional HIV care provider. This included the provider creating a list of our clients' upcoming appointments so that staff did not have to track each client individually. Our team also found it helpful to conduct pre and post screenings in person instead of relying on the client to have a working phone and being able to call or text. Lastly, collaboration of staff conducting these evaluations has led to consensus on what behaviors and statements signal barriers to attending scheduled appointments. This slide shows data that was collected during the QI project. There was a total of 106 appointments documented in CareWare from February through June of 2021. Of these, 65 were attended by the client and 22 were not kept. The remaining 19 were either still pending, it was unknown whether they were kept, or the appointment had been rescheduled. 75% of the clients had pre or post-appointment barriers listed. 73% had pre-appointment screenings completed, and 70% had post-appointment screenings conducted. This slide shows the barriers that were identified during pre-appointment screenings. The barrier most often identified that prevented clients from attending their appointment was transportation, and it was listed in 55% of the pre-appointment screenings. Next was substance abuse in 22% of the screenings, followed by lack of understanding of need for care in 19%, and mental health was identified in 16% of the screenings. Other barriers identified in less than 5% were scheduling conflicts, lack of childcare, poor relationship with provider or staff, inability to contact the provider's office, and lab work not being completed on time. Here we can see Here we can see the various reasons that 22 appointments were not kept by clients. These barriers were identified in the post-appointment screenings, and the barrier most identified in 32% was lack of understanding of need for care. This indicated that staff needed to increase client education so that clients would better understand the importance of seeing their providers as scheduled. Some other barriers that each were identified in 18% of screenings were substance abuse, errors by the provider's offices, and forgotten appointments. This was followed by poor relationship with provider and office staff, inability to contact the office, transportation, lab work not being completed, and scheduling conflicts. Looking forward, it is important to continue to reevaluate data to see if specific interventions are improving our clients' retention and care rates. It is also necessary to increase opportunities to collaborate with HIV care providers. And lastly, it is an ongoing learning process. As we continue to participate in QI projects, we're able to make improvements to help our clients achieve the best possible outcomes.
Awesome. Thank you so much, Emily. Thank you so much, Sharon. Thank you so much, Kate, for your own perspectives on health equity approaches. I love the fact that we have three very different providers in different settings, but they all have looked at health equity and tailored to, what their reach is, whether it's building more inclusivity for vulnerable populations, as Emily stated in her presentation, or building a more holistic approach to meeting the clients truly where they are, as Sharon talked about, or building or addressing barriers in a more rural setting to getting people to attend their appointments, as Kate said. So all three examples really depict great examples of, no matter how big or how small, health equity is achievable in our programs, as long as we're thinking outside the box and also partnering with those individuals so that we can build health equity across programs. So again, thank you to all three of our presenters. I wish we had more time to have more Q&A, but please definitely reach out to our three presenters and you can learn more about the great work that they're doing. So now we are about to enter our last meeting for the day. This is going to be facilitated by Bobby Rogers. This is going to be a bit of a different one. So in your program agenda on the website, there should be a link that will actually forward you to one of our Zoom rooms in a separate platform outside of the website. So at the conclusion of this presentation, you will go into that room by clicking that link, and Bobby will go ahead and facilitate the last session of the day titled "Who Moved My Cheese?" You'll learn more about that pretty soon. So thank you so much, and we'll see you in the Zoom space. Thank you.